go ahead and cruise along here. The ears, an external and otoscopic examination must be performed. Note any abnormalities and a correlation with perceived hearing loss may need follow-up testing, audiometric testing. So this is one of the questions, well, it's a very similar styled question that was on the test. And you more than likely, I don't know anybody who hasn't had a hearing test on theirs. A lot of information on this little question sheet here. So first of all, in the top hand corner, you can see American National Standard. That is the standard that is used for audiometric testing. So that's first to know. Secondly, you will notice that there are 4 frequencies for the left and the right ear on this particular question scenario. Remember I said that 500,000, 2,000, that those were the frequencies used? Well, guess what? That 3,000 that's in there is a distractor. And I had a test question just like this. Other people had very simple ones like this too. It is a distractor. You do not use this in computing in your computation. So remember that you add the 3 and divide by 3 to get the average decibel hearing loss in each ear at 500,000, 2,000 hertz. So driver fails the force whisper test and is referred for audiometric testing. Which the following drivers can be certified? So driver A has 35, 40, and 45 decibels of hearing loss in the left ear, 500,000, 2,000, and 34, 40, and 46 at those respective frequencies in the right. So if you add those 3, 35, 40, and 45, you will note that that would be right at 40. So driver A would pass on the left ear. On the right, it would also pass in that ear because it's averaged out right at 40. Okay, even without using a calculator, that you should kind of see that would be averaged out right at 40 when you add 3 divided by 3. Driver B would pass only in one ear, and that would be in the right ear. On the left ear, you can see 30, 40, and 51. That 51 kind of puts it over the top, so to speak, and he would have over 40 decibels of hearing loss in the ear. But the right ear would be okay. It would be right at 40. So, okay, so does driver B, does he fail? Does he fail the hearing test then? Should he not be certified? The answer is, no, he should be certified. Because what? You only need 40 decibels of hearing loss. One ear, just one. So you only need one ear. And he passes in one ear. How about driver C? 30, 45, and 50, 30, 40, and 60, both ears. You add those 3, divide by 3, and you would fail in both those ears. A little bit of a change on that slide there. If you look down at the bottom, it says average hearing loss, the better ear needs to be less than 40. It's less than or equal to. You need to have 40 decibels or less hearing loss in the better ear. So you need to have a reading of 40 or less on average at 500,000 and 2,000 hertz. This right here is a very similar test question that many people have had on their tests regarding hearing. So driver A and B would both pass and driver C would not pass. Okay. The mouth and throat. Note any abnormalities likely to interfere with breathing or swallowing. You don't have to necessarily go diving each time, but you might. So just need to make sure that they don't have any abnormalities likely to interfere with breathing or swallowing. Okay, we're going to start cruising through several different areas of pathology here, which perhaps in some cases are more obscure, but but still need to have a good general understanding of certification when it comes to cardiac and pulmonary related disorders. So we're going to talk about the heart and the lungs, abdominal exam, hernias, etc. So the heart, basic nomenclature to atria and ventricles. Be familiar also with just your general conductive systems of the heart. Note that, of course, you can have a left axis deviation or a right axis deviation. Your left axis deviations, may also be just a normal in a sense. You may have, due to obesity, can cause a left axis deviation. Right axis deviation, you have right ventricular hypertrophy that is causing this axis deviation, and so there's going to be need to be familiar with some of those generalities of cardiac function and how that might relate also to EKGs, although you don't need to be a cardiologist here. When we talk about cardiac history, some good questions to ask would you have chest pain, shortness of breath, difficulty lying flat at night, might have orthopnea, episodes of dizziness and lightheadedness, palpitations. Most palpitations are innocent but of concern if associated with different arrhythmias. Current treatment of any cardiac condition, diaphoresis. This is the reality, folks, is that docs, we've got lots of folks come in our office, a lot of drivers come in, and they are just like this, that they are really, truly in some bad physical health, and the only doc that they come and see is you. Right, and so it's important for us to intervene and to really do the best job we possibly can with these folks, because they need us to find some of these conditions because they really aren't seeing anyone else. Cardiac examination involves inspection, palpitation, and auscultation. Note the presence of a pacemaker or ICD. So pacemakers are okay. ICDs or defibrillators are not okay. So pacemakers okay, defibrillators not okay. You don't want a defibrillator going off when you're riding a hazmat vehicle in the middle of the interstate. Examples of abnormalities in examination include labored breathing, cyanosis, pitting edema, abnormal arterial pulses, blood pressure, abnormal sounds during auscultation. Note the presence of murmurs and extra heart clicks and ejection clicks and heart sounds. Most of the anterior wall is made up of the right ventricle. Be familiar with your mnemonics in terms of the placement of your different heart valves, the aortic valve, pulmonary valve, tricuspid valve, and mitral valve. Remember, the mnemonic we had was a pet monkey. Some people say that all physicians take money. I think it was another one I remember hearing. But at any rate, you do want to make sure that you can auscultate correctly the different heart valves, because some of your heart valve pathologies you're noting, of course, whether this is an S1 or S2 sound, and whether this is coming from any of the associated heart valves. It's important to know that. So the apical impulse, which is variations in the apical impulse, was found in the fifth interspace, 7 to 9 centimeters from the mid-sternal line. Some of your heavier patients, it is much harder to be able to palpate this, but a lot of your very slender patients and juveniles, adolescents, it's a whole lot easier to actually palpate and sometimes see the apical impulse in between the ribs. But if this is displaced laterally and inferiorly, this may indicate left ventricular hypertrophy. If displaced down to the left, palpate and auscultate. Left ventricular hypertrophy warrants the driver to be found unqualified, especially if there's any symptoms associated with this, to operate CMV until they are more fully evaluated. Your heart sounds are diagnosed and assessed based off of where they are in the cardiac cycle, based off if they're in systole or diastole. Of course, you have your S1 sound, S2 sound, indicating systole or diastole. Clicks and snaps and your rubs, injection clicks. Be a little familiar with those. With women, you can always ask them to move breast tissue out of the way for you to auscultate, perhaps the mitral valve. Remember that breath sounds can alter at times also with inspiration, to just be cognizant and aware of that. And here, when we're auscultating the heart valves, we're actually assessing for heart valve pathology. Knocks and rubs and constricted pericarditis, there may be a loud or low-frequency diastolic noise known as a knock. And any abnormal sound would be considered abnormal. Any additional sound would be considered abnormal. Your murmurs are classified as systolic or diastolic. Again, the location of them is important as well, knowing where your heart valves are at, and characterizing them and naming them according to that is good. Most innocent murmurs are faint. Usually, and these are graded from 1 to a 6, your murmurs. Usually a grade 3 or higher is of pathological significance and should be evaluated more fully. Grade 3 is moderately loud but is not associated with a thrill. Oftentimes you can palpate a thrill. If concerned or unsure, consultation with the driver's PCP or cardiologist is indicated. And so a thrill is a vibratory component. And when you can actually palpate, and I've palpated a thrill before, so just even putting your hand on a person's, on their chest, on their upper chest, and you can actually feel this vibration every time the heart beats. But again, your heart murmurs, grade 1 and 2, generally not pathological, very faint. On your grade 2, you can hear it, and it's consistent, but it's not moderately loud at all. Those that are moderately loud, even if it's not associated with a thrill, should be referred for additional follow-up to investigate that if it hasn't been. And I've referred patients out for heart murmurs. A cardiologist called me and said, "Hey, thank you very much for sending that guy in. We're monitoring him. He's doing fine, but just wanted to let you know that we did that." Remember, your heart murmurs are based off of whether it's a diastolic or systolic murmur, whether it's aortic regurgitation, mitral stenosis, pulmonary regurgitation, tricuspid stenosis, and the opposite of that for systolic murmurs. There's lots of different. I have a Littman stethoscope, electronic stethoscope. Don't have to have this, but it's kind of nice. You can Bluetooth that. So it's nice to have tools that help to accommodate for any weaknesses you might have. I do have some hearing loss in my left ear, and so this you can actually turn up the volume. It has some noise control on that as well. Don't need to have any of the specialized stethoscopes, but you do make sure you do have a stethoscope. And one that is in good working order. Yep, you can use the cheapest ones out there. You could. Make sure you have a decent quality one. This is another Littman, a kind of more lower grade one. But just want to make sure one that has good quality. We can talk about heart sounds as well as pulmonary sounds, but it really doesn't mean much if you haven't auscultated it, heard it for yourself. So make sure if you are unfamiliar with some of these sounds, have never heard them before, first I recommend you do, whether you're doing DOT exams right now or not, just start listening to people. Start auscultating the posterior anterior thorax. Dr. Jack Kessinger once told me and all kinds of other students back in the day, they said that, once you have heard or auscultated 1 million normals, you will identify an abnormal. Now, you may not know exactly what it is, but when you hear a bunch of normals and all of a sudden an abnormal one pops up, you know it's abnormal. So at the very least, you may not know exactly what that condition is, because you're not a cardiologist. I'm not a cardiologist. General practitioners out there aren't cardiologists. Nurse practitioners, a good chunk of these folks out there, are not cardiologists. So what are they doing? They're screening for these conditions, and of course, who are they referring to? Cardiologists. So you don't have to be a cardiologist or a neurologist or endocrinologist. We need to do a proper examination, and if need be, we need to refer people out. And so start listening, start auscultating. But here you can actually auscultate and listen for various heart valve sounds as well as pulmonary sounds. So here's the auscultation assistant and lots of other references out there, different sites you can go to listen to other valve as well as pulmonary sounds. So to evaluate the peripheral vascular system, identify abnormal pulses, edema or erythema, check for capillary refill in the fingertips as well as the toes, ulcers, hair loss, varicosities, auscultate for carotid bruits. For a bruit to be heard, there's normally about 90% occlusion. Auscultate the carotids, which I do on all my patients too. It's not very sensitive, but it's very specific. So it's a fine test to do. If in doubt, you can perform a Doppler ultrasound. Oh, so I'm kind of jumping off page here just a little bit. But so Ned driver came in, and he was also hypertensive, so I did send him out for medication. And he came back 3 months later. But I also, when I was doing my exam, I noticed this weird-looking blemish lesion on his scalp. And I said, what's this? And he said, I've been meaning to ask somebody about that. I'm glad you asked. So do you think I should go have this checked out by a dermatologist? And I said, yes. And so it ended up being, hold on a second here, I'm just checking on a couple things here. Whoops. It ended up being a cancer, and it actually had grown into his skull a little bit. Do I have this? I do. I actually have it here. Okay. So it's 50-year-old male presented for DOT exam, hypertensive, round, irregular lesion on the scalp, and he's referred out. Ended up being a basal cell carcinoma, which is a little bit odd that it had that kind of invasiveness about it, but still is being treated. But the lesion had grown in the skull, was a questionable long-term outcome. So, we're seeing people, especially even if you're doing musculoskeletal work or other nutrition work or other internal diagnostic work, we're seeing people's skin. This is just a good example of it. So, referred him out, and he got some treatment that he needed for that as well. So, here's a question. What's this? Is this a fungal infection? Or is this rheumatoid arthritis, or is this some type of cardiopulmonary disorder, cystic fibrosis, or something of that nature? And it's the last one, right? So this is a type of question that you might have on your test as well. Pitting edema, grade 1 through 4, which has to do with how long the pitting lasts. If you have edema in one extremity, it's more likely to be something wrong with the lymphatics, but if it's in both extremities, left and right, it's more likely something more systemic having to do with the liver, the heart, or the kidney. There aren't complete absolutes on that, but in general, you might have some issues going on with the liver, the heart, or the kidney. So if we're having more and more of that, it's important for us to assess those things in our folks with taking antihypertensive medications or cardiovascular disease, some of our geriatric folks, those that have proteinuria. Again, that could be related to kidneys, and of course, we may have pitting edema from that. We use a Doppler ultrasound in our office for doing ABI index, ankle brachial indexes. I also use that for showing drivers what their blood pressure is, because you can actually pump that up. They can actually hear what their blood pressure is as it's coming down. So if they think I'm making up that their blood pressure is high, you can actually use your Doppler ultrasound. And while you can get the systolic blood pressure, it's safe to hear it, like you see it then coming down. It's a good educational bit for them. You don't have to have that, but it's FMCSA guidelines often require cardiologist assessment, and sometimes there's extra testing such as exercise tolerance tests, ECG, angiography, and radionuclide imaging. There are many waiting periods for cardiac-related conditions. Also, sometimes there's a need for INR monitoring. And sometimes they need additional testing in those areas too. So ventriculogram, you're essentially checking for the ejection fraction. That's one of those tests that is used in the cardiac section. There are 3 basic tests used in the cardiac section. And so if you bring up that page, the waiting periods page, you'll notice under the cardiac box, there are several different types of tests. Just briefly mentioned it there. One of them is the ejection fraction. Okay, so this, and so there's three basic tests in the cardiac section, three basic tests in the pulmonary section that we're routinely interested in when it comes to assessment. And the ventriculogram or the ejection fraction is important. And let's see, what's another one? Well, of course, another one is the ECG or the EKG, ECG, and the exercise tolerance test. Those three tests are very commonly used in the cardiac section. And so with regards to current cardiac conditions that must have no current clinical diagnosis, or they must be recovered or must be fully stabilized from a myocardial infarction, angina pectoris, coronary insufficiency, and thrombosis. Also, any other cardiovascular disease which may cause syncope, that would be bad in a vehicle, wouldn't it? Dyspnea, collapse, or congestive cardiac failure, all those would be a concern and would be something they would need to be fully stabilized from. It suggested that where there is an occurrence of cardiovascular insufficiency, an MI or thrombosis, before the driver is certified, he or she have a normal resting and stress ECG, no residual complications and no physical limitations, and not taking medications likely to interfere with driving. So I've just abbreviated a couple things from the cardiovascular tables, from FMCSA's cardiovascular tables, and you can kind of see what I've done here is I've taken like myocardial infarction, and I've tried to summarize some of the information from these tables, put it all on one page, put 4 different conditions. So on post-MI or myocardial infarction, there's a 2-month waiting period. No angina. You must have no angina. Have a medical consultation with a cardiologist, retesting an ECG or ventricular ejection with a ventriculogram with an ejection fraction of greater than 40%. So that is one of your magic numbers. It's on that waiting period, right up in that top box over there, as the left ventricular ejection fraction on pretty much all your cardiac conditions should be at 40%. If it's not, they need further evaluation or further medical treatment, or they just shouldn't be certified at all. Recertification every year on a myocardial infarction, retest, exercise tolerance test, a medical reexamination by a cardiologist every year. And so I've gone over that also with angina pectoris, with PCI or post-percutaneous coronary intervention, which would include angioplasty, for instance, and also CABG or post-coronary artery bypass grafting. And you can see that I've just kind of converged the information from the cardiovascular conference report recommendation table. So in this case here, post-myocardial infarction, certification status over there, no if they have recurrent angina symptoms. And also no if their ejection fraction is less than 40%. But yes, if they're at least 2 months post-MI, that's the waiting period. And if they're cleared by the cardiologist, and if they have no angina, if they have a greater than 40% of on their ventriculogram, right? So back there with the PCI, you've got angioplasty, you have a 1-week waiting period, which is kind of goofy. I don't like a bunch of abnormal waiting periods. But at any rate, you do have a 2-month waiting period on post-MI, 1-week waiting period on the angioplasty. On your CABG, you have a 3-month waiting period, so you have your artery bypass grafting, 3-month waiting period. So what I usually say is this, excuse me, if you have a surgery on a heart, actual surgery, so you're going in there and you're grafting, you're replacing a valve, you're got some kind of stenotic condition, and you're doing some kind, maybe a congenital, patent foraminovaly, some of these kinds of things, maybe a AAA. You're doing a surgery. It's a 3-month waiting period. Surgeries, 3-month waiting period, except for angioplasty, which is 1 week. Okay, whatever. But all these should have an ejection fraction of greater than 40%. All of them should have an ejection fraction of greater than 40%. So any of your heart surgeries, in general, 3-month waiting period. Now, heart attack, just 2-month waiting period, but your angioplasty is a 1-week waiting period. So there's only one other caveat there, which is when you replace the whole heart. We'll talk about that here in just a moment, but that's a little bit longer, right? A little bit more involved. Heart surgery, 3-month waiting period. Recertification, 1 year except for transplants. All medical examination, re-examination by a cardiologist. Coumadin, 1-month waiting period. Coumadin, 1-month waiting period. PCI, angioplasty, 1-week waiting period. Pacemaker, 3-month. You're doing surgery on the heart, putting a pacemaker in, be a 3-month certification, or 3-month waiting period, excuse me. Defibrillator, disqualification. Remember, defibrillators are disqualifying. And all conditions should have at least a 40% ejection fraction. Stenotic conditions, a lot of these, if they're mild, it's okay. If they're severe, they need to get those surgically repaired. Prostatic valve repair, waiting period, 3 months. Cardiomyopathies, again, your cardiologist, they're doing the testing on this, getting your ventriculogram. Need to have at least 40%. Cardiac arrhythmias, pacemakers, 3-month waiting period. Remember your ICDs and defibrillators disqualifying. Okay, so your atrial arrhythmias versus your ventricular arrhythmias. Your atrial arrhythmias are commonly not as concerning as the ventricular ones. Those that are further down the conduction system tend to be a little more problematic and more concerning. Most atrial arrhythmias are less likely to cause sudden collapse. You should have a medical consultation with a cardiologist, tolerance to medications, which are usually anticoagulants, and this recertification is usually for a year. Most of your cardiac conditions, once they're fully stabilized, most commonly they're year certifications. That's really the way it is with most